Um, so I think that Marla will join us shortly, and I will do her introduction when she starts her slide as well. So just to say good morning, everyone. So this is our final day of MCA week, which has been really, really productive. And thanks to Jenny, who's been helping us to get everything organised and make sure that everybody attends. And it's been really positive. And just I know that people might be we might have some crossover with some of the slides that we've done earlier in the week, but just to say thanks for everybody's involvement and passion in talking about this subject. And we would still like some feedback and discussion on the case studies that we have with these slides today. I think we're only going to be about an hour this morning because we're aware that, there's been a lot of sessions already this week. So Marla and I are just going to try and keep that quite to the point and just to have a bit of discussion around executive functioning and or dysfunction and how that presents and how we can think about assessment. So she should be along shortly, but I'm just going to get started. So some of this we have already covered already, but I'm just going to go through it a little bit more. So this is something actually that everybody has requested quite a lot of times because I think executive functioning is a very tricky thing to really demonstrate, and it's quite a hard thing to really show. So it's been described as the ability to think, act, and solve problems, including the functions of the brain which help us to learn new information, remember and retrieve the information we've been learned in the past, and use the information to solve problems in everyday life. So I think it's that real volition and the thing that you can see when people are making decisions, the things that we do every day that we do. And really, when you can see an absence of it is the functioning is where someone gives what appears to be a good, coherent answer, but it's clear that their actions aren't really measuring up to that. It's not what they're saying that they're going to be doing, and it's not what they are doing. And so their intentions that are being expressed repeatedly are not matching up to that. So really, it's in those answers. And the term executive functioning and executive capacity does appear in the draft code of practice. So there has been that amendment in 2019, and the courts have recognised that these concepts are referred to both in the relevant case law. So already this week we've had Tracy, who came in, who's a doctor in psychology, and she's a psychologist, and she talks a lot about what that means within an acquired brain injury and how it can affect the frontal lobe. So I've used a couple of her slides just to make sure that people understand what that means, because yes, very helpful. So with the functional test of capacity, the most relevant functional element when it comes to executive functioning is the ability to use or weigh the information. So when people can't really weigh up those decisions and really think about that, that's really where you can see that lack of executive functioning. And so that's what we want to look at today. And so both the current MCA code of practice and the draft code link executive functioning with the ability to use and weigh the relevant information. The courts also confirm that that understanding can be relevant to executive functioning as well. So I'm going to just go on to one more. So really it was just to say that these are some of the associated skills that come with executive functioning. So it's the things that we perhaps take for granted on a daily basis, but it's things like setting goals, it's things like planning, strategizing, sequencing, the stuff that you would want to see as part of executive functioning, and that's prioritizing, initiating, self-monitoring, and emotional control. And also when you have that ability to inhibit some of your impulsive behaviors, where you pay more attention, you're able to be focused, you're able to pace a conversation. All of that is part of the skills that come with executive functioning. And those attendance and like focus on detail is really essential. And I think when you can start to see that someone has that dysfunction is when you start to see they're moving around quite a lot. They are not really monitoring their behavior. They are, making plans, but they're not following through. They're not really focused on the managing time and space, and perhaps they are not completing the task that they said that they would. And that's really something that is quite essential to it. And their working memory day to day has those gaps in it that you can see that there is perhaps something that is missing. Yeah. So this is actually a slide that Tracy brought during the week, and I think it's just a really important thing to think about. So it's just to understand the difference between awareness and insight. And I know when I've worked with people who have perhaps some issue with executive functioning, that they will be able to really hold a conversation. They'll be able to say the things that you want them to say in a way in that they are able to present some awareness about perhaps the fact that they have some memory impairment, they have an issue with perhaps organizing their thoughts or their daily tasks, but there won't be really the insight to then be like, right, well, what are the things that I need to now do to prevent that from, escalating, or to make sure that I follow through, I attend my appointments. And that's it. It's that ability to apply the knowledge that that maybe you are a bit disorganized and that you don't have that ability to follow through, but that you are trying to manage that. So sometimes you might see that with people who perhaps have ADHD. They are aware that they have like an inability to focus on those things and they're all over the place. But however, often they will be able to sometimes have insight and to be able to follow through and have ways to manage that. However, sometimes if there is someone who maybe doesn't have the perhaps like function to have a memory around that, they may not be able to follow that through. And that's where that sometimes can happen. So it is possible for patients to have awareness and little or no insight, such as that in a conversation it may appear that they do understand, but in fact they don't. And actually, unfortunately, sometimes it is essential during that assessment to show during that process that in fact that awareness doesn't necessarily mean that they have that insight and their understanding is limited. So it's just about thinking about those people that do present that challenge and how we can evidence that, really. And this is where it's called the frontal lobe paradox, which I think I hadn't really thought about as much in terms of that term, but it was really helpful when Tracy did come in this week, just to really explain what is the frontal lobe paradox and how does it work. And it really is where you have that damage that has perhaps occurred to the frontal lobe. It could be through a brain injury, it could be through perhaps alcohol or drug misuse. And what has happened is that perhaps there is damage that's happened to that frontal lobe, and some of those things are not firing anymore. So from what people say they are aware of to what they do is not matching up. So this is another slide that I did also borrow from Tracy, which is just really demonstrating what the frontal lobe paradox is and how it can really impact executive functioning. So it's really where someone may seem okay and they are able to really present those small isolated bits of knowledge and those nuggets of knowledge. However, it's just not all connecting. So, and that's it really. It's just where that isn't really working. So it is all a bit scattered and those, oh, is everything okay? Can you hear me? Okay, sorry, I just thought I had someone saying hello. So it's just where these things are not really connecting. And it's just where people are, as they say, talking the talk, but they're not walking the walk. So it's just making sure that we think about, are people able to say those phrases? Are they able to repeat things back? But they're not really able to show that they're using that information in a way that shows that they are seeing that that is an understanding, and then they are using that concept to then change behavior or do things that protect themselves, and that's not really clear. So that's what we want to see. So it's just about connecting the nuggets of knowledge and making an informed decision. And that's what we really need to look at. It's like, is someone saying all of these things? However, what is that meaning and what are they doing to make sure that they are either protecting themselves or doing the things that we have discussed with them on numerous occasions, and how do we evidence that? And it can be hard because sometimes people do fluctuate between different states, particularly if people have alcohol or drug misuse, and it can be quite a hard thing to deal with. I'll just move forward. So it's just to really talk about the common impact of
Could I
executive.
ask a question, Lizzy? Sorry.
Oh,
I don't know if
sorry.
you
Yes, I didn't. It's just a bit loud here, so sorry if I haven't heard you.
No.
And
Do you have to have? Do you have to have a? Yes, sorry, Jenny. Do you have to have a diagnosis? of a frontal lobe syndrome or something like that, when
Not
we're
necessarily, and I think with acquired brain injury, or however much it might affect you, it can affect different parts of the brain. And I think particularly with things like Korsakoff's or even like temporary impairment, where perhaps you have a mental disorder, it can affect different parts of the body, like different parts of the brain, in different ways. I think it's just about acknowledging that. So I thought that was quite a good thing that Tracy, who came this week, who is a psychologist, kind of did break that down a bit to explain the difference between the two and how that does manifest. But I would say that it doesn't always have to be a formal diagnosis of a frontal lobe impairment. I think it
just
can,
yeah, because I'm
yeah,
just thinking when we're actually outlining it, particularly for court and stuff, then
yeah.
we don't want to start using what could be diagnostic terms if there isn't a diagnosis there.
No, and I think it can be challenging to take people to the court protection if there is a chance that they may regain capacity, and it can be quite a challenging thing because I think particularly when people are perhaps they have, a substance misuse issue or they have a long-term psychosis. And it can be quite hard to put those things in place because there will always be that state where they may regain some form of capacity eventually, and it can be quite challenging. So yeah, it's
I
just it.
and
Yeah, sorry.
sorry, and folk with that often, as you're saying, they present very well verbally, and that's what the court is hearing. So demonstrating that disjuncture can be quite difficult, and especially, you get the independent social worker or whatever who's having a chat with them once or
Yeah.
twice. Yeah, so we need to explore it really with clinical colleagues to see if we can use the terminology, but we're reflecting that the executive dysfunction is relevant, even if we're not using the frontal lobe paradox stuff.
Yeah, and I think that sometimes, yeah, that's obviously something that is quite defined with the frontal lobe paradox. But I would also say that, that dysfunction can present in different ways, and it's not always going to have that formal diagnosis. But I would agree that, yeah, it's such a challenging thing because one of our SARs that we've had with the Safeguarding Adults Board was somebody who I think we tried to take to the court protection, but I think they had a period of time in hospital, they regained some form of capacity, and it was rejected, and then they eventually passed away. And that was something that we had to take to a safeguarding adults review, and it was really quite challenging because everybody had tried a number of times to take that through a formal process, but they had regained a form of function because they were fluctuating, and we weren't able to put anything formal in place, and then they eventually died. And it is such a challenging situation, and it's just really understanding that it's not. Sometimes there isn't anything formal, but it is, and it's quite hard to prove. But it's just yeah, having that discussion. So yeah, just to talk about some of the common impacts of executive dysfunction. So this might present with someone that you are supporting with difficulties with motivation and initiation. So a survivor so when we say survivor, this is something that I've took from acquired brain injury. So this is something where I think they use the term survivor because perhaps they have survived a brain injury, but it does also apply to people of various backgrounds. But it may be that they lose their sense of get up and go, and also it can be that uh, there is a depression that comes after when someone does have a brain injury. But it also applies to many different forms of cognitive impairment, and it can be difficult to complete tasks. This might be mistaken for others as perhaps disinterest or laziness, but in fact it's just basically about needing to be reminded and needing to focus, and that isn't there. But even though that they intend to do it, they may not have that focus after a small amount of time, and they can't initiate that or focus on that. There's also difficulties with organisation. So the service user might struggle with making and sticking to plans. So even like appointments that we make with people, we will find that perhaps they might not engage with those because they have that dysfunction, either temporarily or permanently. And thinking through the steps to get things done may be difficult. Yeah, so they might not be able to see things through, and sometimes it can be quite difficult because it might seem like somebody is not engaging, but actually they're not able to really focus on something or to have that organizational focus. So a service user might be unable to keep track of appointments and frequently get these muddled up. So this is always something that we'll have to focus on and have a think about whether they have that ability to do so. And they might have difficulties with flexible thinking or to think, outside of the box in some ways. There might be a need to change behavior. So there might be changing behavior or switching between tasks that might be difficult for them. And they may become stuck or fixed, or there might be certain information or behaviors that is quite rigid and focused. And I know that I've seen this particularly with people who perhaps might have Korsakoffs or that where they have that certain behavior they were focused on before, and that's just all that they can stay within. So that's something definitely that might happen. So for example, thinking that lowering the heat is lower the heat of food is unexpectedly cooking it too quickly. So they might, that might happen. So another few, oh, sorry, just 1 second. I think we had a few before this. 1 second. Just to flexible thinking is next. Yeah. Sorry, I just skipped one ahead. So difficulties with problem solving is also an issue that can come up. So it's just being able to understand that this is a way to really identify when someone might be having executive dysfunction, is they're struggling with problem solving. They are thinking through problems and forming solutions, but sometimes some of it might be difficult. So with more complex thoughts or decisions, so it may also be difficult for them to anticipate consequences for their decisions. And a service user may be unsure of what steps to take. So for instance, if they've lost their bank card, they don't know what to do. Or they might be impulsive. They are not really able to focus on things. And they might be, or they're over focused on, just spending money quite quickly. They're not thinking about the wider decisions such as bills. And they're not thinking about what needs to be paid later or the wider kind of long-term decisions. And there's difficulties with planning, difficulties with focusing on appointments and things like that, or making those plans ahead. And it can be subtle, and it can be quite evident. So it's just these things can give that sign that there might be an issue with what people say and what they are doing. So it's just to really start to think about how you show that within your maybe Care Act assessment as well as your mental capacity assessment, how you evidence that. It was just to really also remind people that although there is executive impairment, that there are also it can be hard to really decipher between the two, because you have people who are making unwise decisions. They may appear to be making risky decisions, and you're not really sure what is perhaps impulsive, what is what is between the two, and what is it that they are being impulsive? Is it that they're not thinking ahead, or is it that they just are making that decision to just make an unwise decision, as is their right? And it can be really, really challenging to really dig down in that. And I would say that I've supported a number of people, and I've really, really struggled to know between the two what that is. So it's just to say that it's not always clear. And it's about building up pieces of information and showing that bits of behavior over time to show that you can clearly see that they've said actually they want to change this behavior, but they are not. And how does that work? So sometimes that can be evident. And also it's just about assessing ability to make the decision. So does the person have a general understanding of what decision they need to make and why they need to make it? Do they know why they need to do that? Because sometimes I find with people who perhaps have that borderline executive functioning issue, we definitely need to try and present information to people who have that need, but they can be quite chaotic at times, and it can be quite hard to present someone with that information because they're all over the place. They're not really focusing. So it's really important to, does the person have the general understanding?
Lizzy.
Oh, sorry, I can't see it. Hi, Michelle. Sorry, yeah, do come in.
Oh no, it's completely fine. Hey, I just wanted to add that I think this area of assessing capacity is a very challenging one. I have had a few cases where this has come up, and I did a bit of research and looking at the case law around it, and it's one of the parts of assessing capacity where I think workers can actually make mistakes sometimes because you start setting the bar too high. And, you know, a lot of these, the evidence, I think, really needs to be robust, because it's quite easy to find evidence when you're looking for it in a kind of confirmation bias that somebody is having problems with, you know, taking some of their decisions forward. So, yeah, I mean, following on what you were saying, anyway, you were just saying after I put my hand up about the difficulties of it, you know, and how challenging it is. And I think it's important to work with, you know, manager or other people as well, just to get second opinions, because we have a lot of power when we're assessing capacity. You know, and if you make the wrong decision, you know, taking someone's autonomy away from them, you know, in areas like, you know, finances and things like that, it's hugely impactful. So, yeah, just wanted to add that.
Yeah, and I've also worked in teams where perhaps there is, and it's not always a comfortable thing to say, but there's a service user that everybody knows in the team that has been passed around, has been hard to focus upon. They might complain a lot. And it's just really about thinking about trying not to take that bias forward when we're doing these assessments, because sometimes, you know, they're very difficult. This person might be difficult to engage. They are quite chaotic sometimes. And it's about really trying to, you know, let go of some of those biases that might have built, which can be challenging. And that's the thing. It's like I've sometimes taken on a case and I've had a handover, and it's been very much like, oh yes, you know, and there's all this kind of weight given to a history of someone. And it does add up to quite a long bias if there has been 4 or 5 people before you who've made attempts to assess capacity, where there have been challenges or abuse, or there's been complaints. And it's just really difficult, because that adds to the weight of also trying to do a capacity assessment on top of quite challenging behaviour, and also a general maybe lethargy within a service to try and manage that behaviour. So it can be quite a lot. So
you have a hand up. Greg, like to answer your question?
Yeah, sure.
Yeah, I guess just to sort of outline a quick case example, we've just had a
of course.
Which sort of I think shows the difficulty. So we've just done a review for someone in a care home situation, and the social worker's come back, written the review up, and went, you know, so and so was able to state their views around the placement. There were no concerns around his, you know, knowledge. Yeah, he understood where he was, and etc. etc. It wasn't a formal capacity assessment. It was clear in the write-up that she considered the guy capacitated. And when we looked at the file, there's of course a dog's authorisation in place. And I went, well, this is sort of a little bit strange. It was only done 3 months ago. When we went and I said to Emma that, Emma, we're sort of questioning whether the dogs is needed really. It's you know, our position is the guy would appear to be capacitated. She said, well, that's interesting, because the Section 12 doctor, when he first did his assessment, came back and went, that guy's clearly capacitated, and went, no. And then the BIA went and did theirs, and the BIA came back to Emma and said, he's clearly lacking capacity. So Emma asked the Section 12 doctor to go back and do it again. And then the Section 12 doctor agreed with the BIA. And then 2 months later, we've come along going, we don't understand why this person would be, you know, especially if we go the presumption of capacity, number one. Number two, allowing for, for the person to come up with some things that, I think one of the things that the person said was that they really hope they get better and get out of the care home. I know I need to be here now, but I want to get better. And of course, the BIA has correctly said, this guy's not getting better. He's got very serious illness. He's not going to return home. But it's still, isn't he allowed to have that wish? Isn't that wish okay? Why is that a lack of capacity?
Is absolutely okay, but it does present, and I would say that when someone has that level of awareness, it really is quite tricky. It is quite a tricky thing to sit with, because there's elements of really presenting insight. And I think that I also have had that when people perhaps have had alcohol or drug misuse, or they've had that level of early onset dementia, and they have really quite good levels of insight in some areas, but not in others. And I think it does really present quite an ethical challenge when you're working with someone, because you feel this sense of insight in a number of areas, and that you're also slightly restricting them in others, and it can be
and
quite
I guess
challenging.
we sort of also see the dogs in some way as a piece of legal paper. Does it impact on, is it going to change anything in terms of the person still needs a care home? Well, we all agree to that. So should we challenge, ask the dogs team to consider rescinding it? Should we stir up the pot? Should we just move on to the next case? I mean, obviously, I like stirring up pots, and I'd like to go to the Section 12 doctor. Please explain. I don't understand your position.
I think to uphold someone's ability to ask not to be restricted and to go through that court process is within their rights. And actually, sometimes if it doesn't sit well that someone is kind of protesting against their restriction, then I think it has to go through the court, because sometimes I don't think we're within our limit to do so. I think it's important that we do go through that process, because otherwise you can feel quite out of your, I mean, I definitely feel at the deep end if someone is protesting, and I'm not sure either way whether they should be. And that's why I would prefer it sometimes to go to court. It's just, it is very complex, and I think it can definitely leave people feeling uncomfortable. So all I would say is, that this whole area is very, very dicey at times, because sometimes I do a care act assessment and it will be on someone's good day, and then actually sometimes it will be on someone's bad day. And it's the same with mental capacity, that you will see that someone doesn't fully understand sometimes, but that perhaps someone does see them on a good day, and it is time specific. So it's just about understanding that as well. Sometimes we might need to go back and revisit that. Anyway, I'll just go back to this for a second. So but yeah, do let me know, Jenny, if there's any hands up. Sorry, I can't see, I've got one screen. So does the person have a general understanding of what decision they need to make and why they need to make it? So it's just making sure, I think sometimes when we are dealing with people with challenging behavior, or they're not able to understand why they have restrictions, particularly if they have executive dysfunction, perhaps they might be so presenting well in other ways. And so it's just making sure that we're still following all the steps to make sure that people have all the information related to the decision, and that they do have all of that. Are they understanding the likely consequences, or making or not making the decision? Is the person able to understand, retain, weigh? All of this is essential. And can the person communicate that? And I have found sometimes.
Sorry, Lizzy. Colin has a question. Colin has a question.
Yeah, sure. I'll just finish this slide and then I'll come to you, Colin. So would the services of a professional such as speech language therapists be helpful? And I would also say, would a psychologist be helpful sometimes? Sometimes I would say that we're not always able, when it is borderline, to understand if someone has that executive dysfunction. And it's really important to think about asking for that extra support when it is borderline, or if we are considering going to court. So that's all I would say, is to think about having that extra support. Did you say it was Colin?
Yeah.
Hi, Colin.
Sorry, I had to get my headphone microphone. It's not. It's kind of just a comment. I read something about mental capacity in community care about 3 weeks ago.
Yeah.
And they came up and they were saying that when someone can answer all the questions, understand that there's a problem if they don't do this or they don't do that, everything as if they've got capacity. But then they said, because they go back, and you had mentioned it earlier about people going back and still doing an unsafe behaviour, they almost were saying that they, maybe I misread this, but they were saying that that meant they lacked capacity to weigh up the situation. And I thought, well, sort of, but isn't that what we call a poor decision that they are making because they choose to make it? And it's much better what I'm listening to here than what I read there. And that's really all I was, I noticed, and it's stuck in my mind.
No, it's a really good point, and it's quite difficult because I would say it really is about that. It's about that you. So I have found that, particularly working with people that perhaps maybe have that frontal lobe, not everybody does, but someone who maybe has that slight breakdown in what they're saying and what they're doing. And I find that sometimes I've been able to have quite a clear conversation with someone, and it's been very detailed. It's been very much that it seems that they've got all the information, they're saying all the right things, but also that there was one person who I had remembered assessing maybe a year before, and they were still saying exactly the same phrases. There wasn't really anything outside of that. And then when you were really thinking about what was happening between the two visits, everything they were saying didn't really match what they were doing. And so they would be like, yeah, totally, that's what I'm going to do. And then it wouldn't really add up. And then when you were asking them about what they'd just done, there wasn't really a recollection of that. There wasn't really an understanding of what that had happened. It's not like, well, I just wanted to do that. It was perhaps a lack of insight into why they'd done that or what had happened in that time. And it is all on balance. So it's quite a hard thing. And I do really want to acknowledge that in this session, that working with people with executive dysfunction can be quite challenging when it is on that borderline and it is not always clear. But where you can see that people aren't really following through on what they're saying, and it's not really that sense of determinism, as in like, I'm doing this because I want to. It's just an autopilot of that is just what will happen, and they're not taking on board the previous thoughts. And it is about you determining whether that is the case, and you have to do that sometimes through a number of visits. So yeah, I do know the challenge with that, and it's quite hard. So yeah, I just want to say that, and it's just to say that fluctuating capacity can be a challenge, particularly for health and social care professionals. Sometimes it might be an unwise decision. Sometimes it might be quite clear that, from day to day, they don't, sometimes they have full capacity, sometimes they don't. And it can be inconsistent and unpredictable with decision making. And often we take up a disproportionate amount of time and resources with people who have this need. And it can be quite hard because often they are the most risky service user. Sometimes they're people that really need our help and they need to have that focus, but actually you have to do a number of assessments, a number of reviews, there have to be a number of things undertaken. And if there is that disconnect between the two, it might be that cannot always go to court because they may regain capacity if they, for instance, like stop drinking, or they're in a safe environment where those behaviours are supported, and they then, obviously are calmer. So it can be quite a hard thing, because by the time we get to court, sometimes that's not always something that we can evidence that someone needs a support plan. And also the court often will not support a really restrictive care plan for people who have this level of need. So decisions should be time and situation specific, as we said, and it's often not the time to continually be assessing someone's capacity and recording the outcomes. There may also be a limit on how long decision making can be deferred. So yeah, it's just to be mindful of that. So yeah, I just wanted to say that with this group specifically, but also, there is other groups that we have. But it was found with the Mental Health Foundation that 52% of professionals were assuming the service users did not have capacity before conducting the assessment. And this is obviously contrary to the principles. But it's just to say that I think that we do say that, oh, they don't have capacity. And it's said, you know, with sometimes when we receive referrals, perhaps from paramedics or from police or people who are stating things about capacity. And it's just to make sure that we are starting from point one when we are doing these assessments, because it is really important, and particularly when people come in and they might present in sometimes chaotic and sometimes they might be actually able to make their decisions. So it's just to make sure that we think about that. Yeah, so it's just to say that it's really important with considerations of MCA and executive capacity to reassess and take a more holistic approach. And mental capacity law emphasise the need to balance paternalism, obviously where we're protecting someone, we're worried. And like I said, this group of people who often have fluctuating capacity or we're not clear on their executive functioning can be quite a really risky group sometimes. And I have received emails where someone's like, well, can't we just put them in a placement, or can't we just have this happen? But then, you know, perhaps they're on admission and they present very well, and we need to make and respect their ability to make a decision at that time. So we might need to repeat an assessment, and we might need to look at whether there is long-term damage, perhaps to their ability to make long-term decisions, and that might be affected. So you can conclude that a person lacks capacity to make a decision if they cannot understand, use, or weigh. Then it might be important to consider what they say in the assessment that they will do. But we can only reach such a finding if there's evidence of a mismatch. And like Colin has said, it could be that they're just making an unwise decision. It's not always clear. And I think that professional curiosity is really the thing that's key, particularly when people are bouncing in and out all the time. We still have to have that curiosity. We still have to have that deep dive and that questioning that goes a bit further. And it is really important. Sorry, did someone say something? Oh, sorry, I heard something. So I've been talking at you for a bit now. But let's just have a small exercise. So I just want to talk about Barry. So Barry is 68 years old. Barry was in the military and reports experience of PTSD, so post-traumatic stress disorder, depression, and has alcohol dependency, and is known for addiction services. So he's been street homeless and on and off for 20 years, and is currently sleeping on the streets sometimes and sometimes in hostels. He has an appointeeship to manage his finances. So this is someone that we did deal with regularly. They would sometimes bounce into the civic centre asking for money, and it would be but then sometimes when they were given money, they would be financially abused. So Barry repeatedly appears in the hospital with injuries from falls, assaults, and has been seen at times confused and to not really know where he is or what's going on when he's really at his most confused. And Barry reports he does not wish to move into accommodation and he is fine, but does sometimes state he's worried he might die on the street. So, and he obviously, and he says at this point that he's scared. So it's just really to ask the question. So you're completing an MCA on where he will live. What are some of the challenges to the assessment here? So just to ask this, because I think this is, well, just going to zoom in there and come up with sharing for a second so I can see everyone. Oh, hi, Marla. Sorry, I didn't see you before. Hello. Hi. So it's just to see what people's views really are on this, on how you would approach this, and some of the challenges around that. So what are firstly some of the challenges with this fluctuating capacity? And I think this is something that a lot of people have dealt with, or even if people can reflect on how this has affected them when they've been trying to assess. Anyone?
Andrew.
Hi, hello. No, I just want to say this is really relevant to the SMT team that I've come to since November, and that there is that. Sorry, I joined late as well, so you might have mentioned this. There is that article from Michael Preston Shute around this issue that we've been looking at, And some of the things that article talks about is a lack of specific guidance around applying the Act to chronic dependent drinkers. And then some of the things that you've mentioned, I don't want to shoot through things too quickly, but things like executive functioning, very, very hard. One of the social workers, sorry, I can't remember who it was, somebody mentioned that. But yeah, just basically we're working through that document, and it covers all these things. And we're, I'm still working out myself, because I obviously have not been in substance misuse that long, but applying it to this service user group is really a challenge, I think. And I think there are negative stereotypes around. There's a stereotype around of, oh, it's a lifestyle choice, but when you're trapped in there and it becomes a health issue, and you have all kinds of things like seizures and other health issues, it is a health matter. I think there's a public perception issue here as well.
Yeah, no, I would absolutely agree, and I think there is definitely a prejudice, unfortunately, to the service user group at times when, and I think you sometimes see it with also women that are experiencing domestic violence, when you are returning to a behaviour that places yourself at risk. And I think there sometimes can be a bit of unfortunately, and I don't agree with this, but like a bit of a lethargy with people who are re-entering risky behaviours. And I don't necessarily agree with that, but sometimes I find there is a bit of a judgment to people who are placing themselves in a position of risk, which might be through addiction, or it might be through placing themselves in the way of harm. And I can sometimes see it in the referrals that we get, that there is a sense of judgment around that, and a lack of curiosity as well.
So I didn't explain the thing I was trying to say properly, and I think when you spoke, they just reminded me that the kind of the fact that you can make unwise decisions.
Yeah,
and that when you're sober, you can say, I intend to do this. I intend to go and detox or go to rehab. But then you could be saying that for years on end, but you're unable to put it into practice. And why you're unable to put it into practice is a very difficult thing to identify. Why that person within themselves can't put what they intend to do into action, and whether they can understand all the dynamics of that. That's very hard to assess.
It is, and it's also understanding that, a one person who presents, perhaps an empathetic and curious approach can actually really quite deep dive and understand and unpick some of those things. But it's just not going on that autopilot with this, approach to assessment. So yeah, no, thanks for that, Andrew. That's really important. So yeah, it was just with this slide just to have some reflection on some of the challenges that come up with this, and also what are the things we need to consider when someone is in this position. They are low in mood, you perhaps bouncing in and out of hospital, and how we might approach that as a group. I'm going to go to Rosemary and then Tamara. Rosemary.
Yeah, I'm referring to what Andrew said. I'm keen to know, at what point do they use the circle of change to try to work with people with the SMT?
I mean, I imagine, Andrew, that the cycle of change is quite key to what you do.
I think the quick answer is it should be used all the time, really.
Yeah, I agree. Yeah.
So in a case like
and
this,
pre-contemplation.
Could that be employed?
Yeah, I'm sure it can. Absolutely.
Okay, thank you.
So just for others that I'm going back to my psychology days now, but obviously with the cycle of change, it is around those behaviours that demonstrate maybe a readiness for change, or maybe a contemplative element of change. And then perhaps sometimes there's that stage just before you're ready to do so, or you're acting on it, or demonstrating those behaviours of change, but you might not actually be implementing them. And then there's eventually those steps that you take to make change, and that might be in an addictive cycle. So just for those that aren't familiar with it. But Marla.
Thanks. I think it's really interesting what everybody's saying, and I'm going to use this to plug what we have all committed to as a partnership.
Yeah.
It's that coming together, because the barriers of this world will exist, and the issues are who makes that decision as to how you know, how safe is that plan going to be. So yeah, I don't wouldn't have the answers. I know all the pathophysiology. I can tell you all about what it does. And on top of that, a lot of these people who have addiction problems may also have diabetes. And if you put all of that together, the death of all your neurotransmitters, there is information, but no joining them together. So all of that, if you put it in, it's a complete nightmare to try and unpick, really, for this person. So these are the sort of people you see as those who self-neglect. And that terminology, self-neglect, really sits within safeguarding. And I think this is where we need to come together. We need to have all that information. So for things like whether they can carry through information about what we've said is through that dialogue. So you can tell me the last time they were discharged, this was the plan put in place, but within a day they went back to it. So you start to gather that information. We all have information, we gather them. That's when you make that collective decision, because not one of us either has the answer, nor should we be making unilateral decisions. I think it's about coming together. It's not easy. A lot of them, those patients who are addicted, we get them all the time. They've got through the phase and they're actually quite sober, and they can be quite meaningful in terms of what they say. All it would take is, I want to go out and buy myself a packet of cigarettes. So restriction, part one. No, you can't go out at all, or somebody has to go with you. So that restrictions already start there. The second thing is, a friend or a drinking buddy turns up, you have no rights to say you can't meet them. Then they'll say, oh, we're going downstairs for a little bit. It's that influence. How can you separate the person from their current life? It's not, it may have been a life choice to start drinking, but you got to look at, it's no longer that. Addiction in itself renders you incapacitous, as the High Court has stated, and also the fact that you're not, that then it fluctuates. If you're drunk, you can't make that decision when you're sober, but that sobriety takes a long time to achieve. So do we have those services? And quite often patients come in because they've had seizures because they're withdrawing, which means they've got to constantly be drinking alcohol in order not to have these seizures. Then your liver is packing in. So massive. If I want to take this to court and say they've got to go into a setting, for instance, and say it's going to be hugely restrictive.
Yeah.
And can we do that? And also sometimes if they're not ready and can't understand that, because frontal lobe disorder often renders you unable to make those connections, then they're not ready. So it's a catch-22.
No, I agree. And
we need to come together to decide on risk taking and what we do and how we monitor the situation. It's no other way around it.
No, and that's what, you know, with you know, collective risk management meetings, I think it's so important that we don't just carry that risk on our own, because it is just sometimes that you just have this gut feeling that someone is going to call you one day and that person might have died, and you're carrying that worry and that risk, and because you're seeing them make these risky decisions, and it does require a lot of long-term work, a lot of chipping away, and there is that real yeah, it's quite difficult, and sometimes you're not quite clear. So yeah, I see that Michelle's put in the chat that yeah, so neuroscience in addiction, it does say that it does indicate that frontal lobe can be impaired, and that it might be that what we say is an unwise decision. And I can see a lot of people being labeled as making unwise decisions, but actually when you drill down into that and you really do that detailed capacity assessment, would we say it's unwise, or would we say that there is no insight there, and that actually we're in that cycle? So you know, sometimes you can see that there is an assumption there that it's unwise, but there's not necessarily that dig down into that assessment. So yeah, thanks for all that feedback. It was just to so I'm gonna let me go back to the slide. Yeah. So yeah, it was just to really go into some of that. So George and Gilbert also recommend that collateral information should be sought from clinicians who have conducted functional assessments with and family members. So I would always say that, you know, if you are having difficulty, do seek extra support if you're not really clear. And in the same way, MCA assessors should check the validity of an individual's self-report, because ensuring that it is congruent with, you know, performance in everyday life. Does it match up? Does it really? And yes, there is unwise decisions, but I would say addiction and sometimes duress or being under the influence of lots of people who are perhaps, you know, assisting with addictive behaviors or enabling, doesn't necessarily mean that that is an unwise decision. It might be that there is it's not really clear. So holistic assessment is essential, and detecting the more subtle effects of executive impairment is really important, and that we should really be done over a long period of time, which, you know, it can be challenging, particularly as often, you know, people don't want to necessarily engage. So this approach does not sit neatly, you know, with the legal definition of determining of capacity, but it is about thinking about decision, time specific, and thinking about the difficulties against legal standards. I'm going to pass on to Marla now, who's also got a case study, if that's all right.
So you might not have read this. I'm just going to give you a minute just to read through this. And I think reading through that, you'll probably, some of you might know who this person is. And then
I did slightly change it because I thought it was a little bit too obvious. So,
but it, oh yeah, you've changed it to Mr. A, but it goes to FRF.
I know, it's my fault.
I should have taken that.
I didn't realise it was on.
It's okay, you all don't know this person. Even if you did, it's not who we're talking about. But the situation is what's important, isn't it? It's
yeah, and I think it's something that definitely arises with hospital admissions, and also, yeah, with Andrew, obviously we talked about SMT. It really is quite a challenging situation when you have such a regular risky situation presented all the time.
so if you read about this person attends very frequently, but he also leaves very frequently. Also, it doesn't stay anywhere very long. But then you think about it. So if your recent memory isn't good, there's something there that always takes him back to one of those places that he used to frequent, or where he went to for support. And he keeps going back there, even though that place doesn't exist, and keeps going back there. So it's about that level of creative thinking and saying, short of grabbing him and putting him in a care home, locking the doors, which we can't do, because I think that's one of the most restrictive things to do to somebody, but understanding their limitations. It's how can we get a team, either through monitoring, making sure he's had something to eat, something like that, but on his terms. So it's using, say, the health inclusion team to check on his blood sugars, somebody else, but keeping him where he is and where he's familiar, because if you don't, you take him places and more likely for him to get lost, not knowing where he is. So there are lots of those issues. And executive functioning, for me, it's long-term substance misuse is a question we'd ask. But when he's actually sober, he would actually say, of course, I want to abstain and I want to do this. And he had really tried, he had. But what you can do is you need to take the person away from their community. And that's not simple, because he's back with the same friends and then it goes back into the same thing. So that impulsivity, oh, I've seen my friend, oh, we're going for a drink. Yeah, of course we go. Everything doesn't matter because the connections aren't as robust as they should be.
Yeah.
So how do we pull? That should be the last thing that one would want to do, is to take him away from where he is and put him, you know, somewhere like a setting in Eastbourne, for instance. And that's damaging as well, simply because he'll start looking for familiarity and he'll be heading back this way. And whatever happens for him doing that. So I think we hear everything everybody's saying. And I think with this gentleman, mark me if I'm wrong, Lizzy, we had that meeting. We all
Sorry, I've just got loads of noise here. I hope no one can hear it.
A lot of information collated, but also looking to see what is the best thing you can do for that person right now, especially when they're quite still fairly able-bodied, which means they can get up and walk out.
I think it's also just, these are the kind of cases that make you worry a little bit when you go home, you know, because you know that someone is on that borderline of possibly, you know, you're going to come in the next day and find out that they're you know, they possibly passed away. And I think there was a case which is one of the SARS that we've got, and we attempted to take them to the court protection, but by the time they were in a placement and they'd gone through that process, the court said, well, what do you want us to do? We're not going to provide such a level of restriction, and they are presenting now as capacitors. So it is just to acknowledge that this is a really hard situation where you have someone coming in and out all the time and placing themselves at such a high level of risk with not clear executive functioning, you know, that goes in and out. And this is a similar case. So I'll put this back onto the thing. It was just that I was trying to mute myself as it was very loud around here. So, so I'll just go on to the next. I think, is this where, yeah, the questions. Yeah, so just thoughts around something like this when there is a care plan, and how, yeah, just thoughts around how we approach things like this. Sorry, just to go back, how we would approach that and some of the challenges that come up. I'm not sure if ever anyone has had a similar case or similar to this, and thoughts around how you approach this.
Sorry, does it approach what did you say?
So just generally how we would approach something like this as in this case, and how analysing and approach to assessment of these needs, which, you know, are fluctuating and challenging. You know, they change on a daily basis, and it's regular readmission on a daily basis and in and out, which is the only kind of almost protective factor, just to see what people's views are around how to manage that. Catherine.
Hey, it's so difficult, isn't it? So I suppose there's a few things I would be thinking about. One is he not drinking till he's with the mate? And actually moving area can make a big difference. I've seen that with folk with court calls, you know, where they can move away and they haven't got the triggers, the social triggers and things that bring them back into the drinking. I agree that locking him up, jailing him to prevent him from drinking to extend his life by a few years is unlikely to be proportionate. And I think sometimes we have to make the decision that, okay, the person may lack capacity, but they have expressed a preference for doing this behaviour for 30 years, 40 years. And we have to accept that that's how they're going to continue, and that the preservation of life isn't always the ultimate, well, it's not the ultimate goal, is it? It's about the quality of life in that person's eyes. In those cases where someone is repeatedly admitted to hospital, I think there can also be a discussion about thresholds for admission. Now, that's potentially more in psychiatric than in acute physical, mental health side, where we say actually we're going to tolerate a higher level of risk in the community. So I think I would stay away from compulsion unless, yeah, I think I would try adjusting lifestyle factors as best as possible. So seeing what is it that is crucial to this guy about the drinking. Part of it's going to be that neurological or chemical addiction side, but part of it's also going to be the social or the underlying therapy type needs and stuff. So seeing if there's other ways that we can meet those. But I do think possibly a location move for this guy would be of value.
Yeah, no, I agree. And I think that sometimes what was positive for this gentleman, sorry, Marlo, I know this is your case, but it was just to occasionally, a couple of days a week, they would come into the hostel, and it was just, that was a risk reducing factor, just even a couple of days a week. And you know, I remember working in you know, a hostel, you know, in Liverpool, central Liverpool, and people would be horrified to find that we were giving cans to reduce risk of seizure, cans of alcohol. But sometimes it is about thinking about what is the lowest risk compared to someone being on the street, or at one point, I think drinking some of the hand sanitizer in the property. You know, it was like, you know, that's what happened at one point, and it was like, actually, it's more important to think about risk reduction than risk removal. And I think that is, you know, it's about how we manage and make quality of life better, you know, in that period of time. Yeah, so I agree.
Can I say, because yeah, we've got places where someone can get their breakfast can, their lunchtime can, their afternoon can, and that kind of keeps them going. One thing we get a lot of pressure from health professionals is, could you please do a pointy-ship? Because they're spending all their money on drink or drugs. And it never works, never ever works. It just sends folk out begging or stealing or getting into debt. So just urging everybody not to see a pointy-ship as a resolution to addiction.
Yeah.
But
Absolutely.
I know I'm preaching to the choir here. I really should be saying something else.
No, that's fine. Andrew?
So I just made a really quick list. I won't take long. I thought about the MDT approach because there's obviously medical elements to it, and detoxing someone with alcohol is a very medical procedure involving psychology because of all the, you know, the revolving door type admissions, harm reduction approaches. The bit about family, if they're supportive, then to maybe try and look at increasing contact with the family, not regarding this person as an individual, but in general. I'm just mindful that sometimes people who have addictions, they're coerced or pushed by other people, by family, by friends to go and seek treatment. So just to be mindful of that, but it's not the case here.
No, thanks for that, Andrew. Yeah. Marla, you work with this person. I mean, what are your thoughts?
Yeah, it's difficult. All I'm going to say is it isn't one person's decision. It's very, very hard. And I think we need to come together regularly to figure out what this person's doing. But I think trying to monitor where they are, you know, everybody who knows this person needs to be aware of where they are, because at this minute in time, they're not quite ready to want to be here. As much as they abstain, you turn your back, off they go. So it's a tough one. So I'm just coming back again to the complex pathway approach, because as I want to make it at any of the meetings, I want to say, I don't want to have to attend any more SARS, because you know what? You come back with 6 bits of learning from every SAR. So if you turn it round the other way, let's put those 6 bits into use now and be able to say the outcome may not be what we would all desire it to be. The outcome's not going to change, but it's how you've managed it, keeping the person in the middle. But also is reading a bit more about changes that people make, the restrictions you place. It should always be kind of in tune with the Human Rights Act. They want to make sure that it actually sits within that, and that your duty to adhere to that is clearly within it. So it's that more of an approach, and I think it's a really good time to think out the box.
I agree.
Like them.
I think sometimes you see these referrals from someone who has got no presenting need. They've not come up on any kind of radar before, but someone's kind of like gone over and done a repair and seen that the house is in a mess. And I think, you know, we've made a few attempts, but I would also say people have the right to privacy and a right to family life. And if they haven't got any presenting need, we also need to think about whether that is appropriate for us to continually harass people as well. And if they're not impacting on locally and there's no risk. So it's just thinking about the proportionate response that we have. And it is challenging, but also making sure that we don't always deflect that MCA decision or MCA discussion to another professional, because this is also what comes up in SARS, is that, oh, well, I thought that might be for the GP, or I thought that might be for a social worker, I thought that. And it's just making sure that whoever has that tries that assessment, even if it maybe isn't fruitful. Because sometimes people don't want to have a conversation with you, but we need to keep trying if we can. Yeah. Let me just go back into my slide. Sorry. Just going. So let me come back. So I think it was this. I think we've covered most of that, haven't we, Marla?
We have, and I think one of the other points, again, that's probably causing this to be a vicious cycle is the fact that this person consistently runs on high blood sugars and the damage that does to your brain.
Yeah.
That adds on to the fact that your brain's not already functioning, and then you take the alcohol, so it's perpetual, it just goes round and round, and the damage is being done all the time. So again, how do you, we don't have the structures yet in place about how can you make sure their diabetic medication is being taken, and we are looking at all sorts of ways to try and make that a safe way to communicate and do those sort of things. Catherine might have the answers. Hands gone up.
Yeah. Catherine?
Oh, I think I'm second. Oh no, you just
sorry.
the diabetic stuff. I think that's where the MDT is absolutely crucial, because too often people are pushing the responsibility for the diabetes management onto social care, and it's health responsibility, the MCA, the BI, and we've had GPs saying to us, no, we don't do MCAs. We've had diabetic nurses saying, yeah, we're not trained. And I think that's something that wherever we see, we've got to be calling it out and potentially collating it, because it's a systemic problem, and certainly in mental health, it's resulting in the loss of toes, feet, hands, and life.
Yeah.
Folk are dying 20 years earlier than they need to be, because we're not addressing this. And again, there might not be proportionate means to compel the person to take the medication. What are you going to do? Hold them down and stab them? But that needs to have been determined through the proper process to give folk their legal rights, hasn't it? So yeah, please, whenever, and I would say email Lizzy if you're encountering who are refusing
Thank
to
you,
do
Kath.
it. She'll keep a list.
No,
it
is true, and we have ways of escalating to GP leads and lots of ways, and I would say, if you're not able to get everyone around the table, then let me know, because we need to be pushing for that and have joint responsibility. Because I think what we had with SAR HI&J was 3 people who had all had that sense of self-neglect, diabetic or some other form of complex health management issue, and then it wasn't being addressed, and it was being this tennis approach of like, oh, it's you, it's you, it's you. And then they came to really quite severe harm, or one of them passed away. And if that is where it's at risk of, then let me know, because we need to prevent that from happening. And I don't agree with this tennis match approach. So we have to get everyone around the table and have a shared risk management approach. Yeah. Sorry, Marla, I haven't, there's a couple more slides. I'm waffling a little bit. So I think the next slide, let me go back into, I think this is still from you. So just the summary slides now.
Am I doing this? Sorry.
If that's okay, yeah, sorry.
Yeah. So I suppose it's just summarizing everything that we've talked about so far. It can be described as it's about the ability to think, act, solve problems, because it's all pieces of information you have in your brain and your neurotransmitters. Put them together. If it's joined up, your awareness, then it leads to insight and that sort of stuff. So remember and retrieve the information we've learned from the past and use the information to solve problems going forward in everyday life. So the absence of such functioning is where someone gives what appears to be coherent answers, and quite often they are what we tend to look at as slightly rehearsed responses. I know what I'm doing. Yeah, this is exactly what I'm going to do as soon as I get home and all of that. But it's clear from their actions that they're unable to put into effect the intentions expressed in those answers. Just what Michael Preston Shute will always say, it's, that are they doing, can they do what they say they are going to do? It's seeing whether they can do that or not. And Sir Martin was a good example of not being able to do what he said he was going to do. So the term executive functioning or executive capacity does not appear in the Mental Capacity Act, although there was some reference made to it in the Amendment Act, the MCA Amendment Act, and it appeared in Chapter 4 or 3 or 4 within the Code of Practice, but the status of that were unclear. But actually there's enough case law for us to say that this is relevant and we need to take this into consideration. And the functional test of capacity, and the most relevant functional element when it comes to executive function, is the ability to weigh. Always think that's really what it is. If they're saying, I'm not going to do it, but they need to clearly say why they're not going to be able to do it. And does that really make sense to what it is? So it's as you say, but both the current MCA and the draft code clearly link executive functioning with the ability to use and weigh the relevant information. So you may actually assess somebody and think they have capacity. So that's absolutely fine. And you put your plan in place, but then you hear they haven't done a thing you've asked them to do. So that actually becomes the collateral for the next time that comes round, unless, of course, it's going to be hugely detrimental to that person to not want to, for us not to act at that time. So the courts have also confirmed that understanding can be relevant to executive functioning. So in summary, I think somebody had their hand up.
There's one more slide after it as well. So
Okay.
I'm not sure who they've got a hand up. Right.
It's me, sorry, it's Alba here. Yeah. I wanted to say, 1 second. Yeah. I wanted to say that this executive function of functioning, when I had a case, or I have many cases, I think, when the ambulance, for example, attends somebody who really, the neglect is horrible, but the person say, I don't want to go to hospital or whatever. They leave it because she said that. I think there is no MCA there often. I don't know often, but my case, I have seen several cases, and they don't consider this person is not thinking enough. They clearly they cannot organize anything for themselves. They are neglecting and they are putting themselves at high risk. So this is one thing I wanted to say, and also sometimes happen. When I'm dealing with some health professionals, they say, no, the GP said that she has capacity. I normally ask them, yeah, I need a copy of that, just I need the document to see what, because I can get that information from my own assessment. Okay, and the third thing I would like to ask Mala is okay. Karasu, sorry. Can we have that case laws about because the law is not it doesn't mention the executive function, but we know this has to be part of the waking up part. But if we can have that information, it will be very helpful to add when I do my next assessment. If I need to add that information from case law, thank you.
Everything you say is totally valid, that it happens. But I think that's the strength in Lambeth, is that we have a partnership, and that's how we need to use, because the law is actually quite clear, the Care Act. We have a duty to cooperate with one another. And quite often, if we say this person needs to go into hospital and then we walk away. And then the ambulance people come in, they have nothing. So they will speak to the patient and say, okay, fine, you want to stay at home, I'm going to leave you because it seems okay, and then walk away. So it's about how we manage that process. I don't think anybody means to be difficult or, not want to hear what we're saying, but I think there needs to be a little bit more joined up working together in that sense. So it says case law highlights the need to probe when undertaking capacity assessment. So quite often it's more of a conversation as opposed to a framework. So I don't know about everybody else. Having been in this job for long enough, you think we tend to use the law as the guiding principles, but actually the law is there to support decision making that we do. It's just we all, in fact, all of us here today probably know what needs to happen, learning from each other, professional curiosity, talking, adding collateral, making those, we all know that. We just need to then look to say, are we within the guidelines? And it's there to guide you, but it shouldn't be the be all and end all before you even hold a patient. So I've just got 3 more points and then over to you, Lee. And then to bear in mind an interview style assessment, real world observation of the person's decision. Again, the same thing. It's having that conversation. So something as similar as somebody, with a mild learning or disability saying to me, yes, I do not want to be touched. I'm going to go home and I'm going to get away. And that's not going to work. And the person says, yes, I also know that if I don't get my treatment, I will die. End of, go away, leave me alone. And is that what you would call weighing up? So the next thing is have more of a conversation saying, what are you going to do when you get home? I'm going to celebrate my 60th birthday. So 1 minute you're going to die, but the next minute you've got your purple balloons ready, your purple cake, your dress all bought and everything else. So you think to yourself, really? Kind of doesn't add up. So you continue that conversation and then do that negotiation bit about, let's start from the beginning. So it's always probing, ask, because they'll say, yes, they said if they didn't have it, they will die. They understand that, but it's that meaning of what that actually means to them. One-off assessments for executive functioning, as it's not the way, but when you do as a team get together, I'm sure we've all bring together issues of when it hasn't worked. That's your collateral. That's what you happen. That when you bring your GP, your mental health professionals, everybody together and look to see if this is a pattern. And also consider whether practical support can be provided to someone experiencing difficulties with their executive functioning to enable them to make those decisions. Get them at the right time, get them when they're slightly, when they're detoxed. It's trying to get the best out of and give them the opportunity. So that's all I was going to say. And I think, Catherine, your hand is up as number 1.
Yeah.
Sorry. I just want to say we had an amazing case of this. Now, obviously, the decision to accept treatment or accept investigations, again, that's a clinical decision, doesn't it? So that assessment needs to sit with the clinical teams because they need to consider things like what's that death going to look like? Is the person aware of the processes? What would treatment look like? What are the symptoms going to look like? And that's, beyond us. But we had a case where we worked very closely. It was a gentleman who had end-stage renal failure and various other bits and pieces and made that decision at the age of about 38 to die. And he had complex mental health issues, so we worked around how those could be impacting. And finally, when he made that decision for the first time in his life, he was happy and he was free. He went and arranged a party, as you say, with the purple balloons and all the rest of it, and had everybody together for his last hurrah sort of thing. And then over the next few days deteriorated and passed away. And it's one of the best bits of work we've done. And for the clinical mental health team, it was really profound because their whole training is preserve life, preserve life.
Yep.
But again, just to flag up that whilst we contribute to those decisions, we categorically wouldn't be the ones taking them. But it can be a really positive experience.
Brilliant. Who was, was it Lee?
Lee, did you have a question? That popped off.
Hi.
Hi, Lee. Right.
Thank you so much for your presentation. So I just wanted to ask, I guess, to gain some clarity and reflections around balancing the principle of executive function and the principle of making an unwise decision. So as we know, the three principles are, if someone is able to understand, weigh, and retain, then they do have capacity. And then if they are ticking all the boxes leading to them having capacity, but the executive function is demonstrating that actually what they're saying they're able to do, they're not able to do it. So in a situation where someone has capacity and physically they're not able to do what they're saying they're able to do, and then you explain the risks to them to say, look, if you don't get your care package, you suffer neglect, malnutrition, and all these things, and they demonstrate that actually they understand the risks. So, now within the Mental Capacity Act, they've got the right to make an unwise decision. And even though that decision is detrimental, so how do you balance those two?
Yeah, I'll let Marla go.
I'm gonna make a go of this, and that's exactly what this is about. So if you work it backwards, so say something untoward has happened, so work it backwards. What will I be saying to a coroner or a judge as to what my actions were and how defensible they were? One of those issues. So I always look at it that way and think, what is the expectation that I should have done that is reasonable to ask of me? And quite often, so in this case, it all depends on that decision and about the level of risk. So where someone, say, I'll give you one of those risks about somebody who's a patient just newly has had a tracheostomy put in, but has taken no interest in keeping it patent, understanding, cleaning it, whatever, and then decides I'm going to go home for the weekend and has got no equipment in the house. So it's an unwise decision. And that person's logic was, if you make sure I'm okay, I'm going to go home. I don't need to do anything, but I'll be back first thing Saturday morning, which is the next day. Now, is that an unwise decision when you can actually predict if that occludes tonight, he's dead? And I suppose that's where you think, in a situation like that, what's my positive obligation? I would go for a second opinion. I would ask a different colleague, maybe somebody from, I don't know, you don't want to hear this, Catherine, somebody from psychiatry to come and do the same assessment, looking to see how we can make it safe before they went home. So there are lots of things you need to consider around it. But if it's something where the risk to life and limb, as it says in law, isn't that great, you want to be able to sort of, sometimes their way of learning would be to make that mistake so that you can record it. You can say to them, but we did explain this to you. It's understanding what that is. So I suppose it's not a one size fits all. I think you still would need to look at each case individually and then look at the decisions and the risks associated with them. I would always look to my colleagues, whether it's over a phone call, whether it's over MST, is to look to say, what would you do? Because the expertise lies within this group, not here and not there. It's within this group. I don't know if that answers your question.
I also think there's evidence sometimes, like in daily life, that you can see. You might be asking a wider decision, but someone in their accommodation will see that what they say versus what they do is a daily thing that they're not absorbing. And I think it is about that background, that information that you obtain as part of your assessment background, that you will be able to see that day-to-day understanding of what people say versus what they do. It's not, they're saying all the right things, and you can see genuinely that they wish to make that decision, but then that immediately goes, they don't have that connect at the next point. And I think there is a difference between someone who I've worked with who was like, actually, I'm telling the social worker this, but actually I don't care, and making an unwise decision versus actually, I sincerely want to change this, but I can't connect the two after. And I think you can pick it up. You can see it sometimes. You can definitely see the difference sometimes. It's not always unwise. It's sometimes uninformed because that's not really firing within the brain, I think, sometimes. So, but it is about sometimes that gut saying that. I'm aware we've got 3 minutes, so we're meant to be finishing. So that went on a lot longer than I thought. I hadn't done that many. And I know this is a really complicated area. I would just direct everyone to the executive functioning session we did a year ago, which is on the calendar. And it is that we did with the neuropsychologist last year, and then also the one that we did this week, which again just talks about some of the basis of what you say versus what you do, and it really goes down into the deep kind of understanding of that. So do rewatch those videos, because it really does help you to understand how that might present, and I think it's quite helpful for the day-to-day assessment. Anything you want to add,
Liz,
Marla?
Can you kindly send us a link to those videos, please?
Yeah, so there's a link on the calendar that we sent, but we can resend that, no problem. And
Thank you.
There was a video that went out yesterday for Tracy's session. I think it's Wednesday session. So yes, but we can resend all of that out, no problem. Yeah. And also the slides will be going out to everybody. Anything you want to add, Marla, before we finish?
No, nothing further to add. No.
Okay, yeah, it's still a massive subject, and then there's a lot to cover within it, but it was just to have a bit of reflection and discussion, because it's quite a lot to unpick. And I think we'll probably do another lunch and learn maybe within the year, just to talk about some cases that people have, because it's quite a big subject. We've got one more session, which is the IMCA session at lunchtime. So just to encourage everyone to attend, and yeah, thanks everyone for attending today, and thanks, Marla.
Thanks, Lizzy. Thank you all.
All right, thank you all.
Thank you. Bye-bye.
Thank you. And thank you, Jenny, as well.
Bye-bye.
Thanks, Jenny.
Thank you.
Thank you.
Thank you. Bye-bye.
Thanks, Lizzy and Jenny. Thanks,